We will speak about the tools to assess recruitability and to recruit the lung. I have some conflict of interest. I'm part-time working for Hamilton Medical in the research unit. These two studies measure the amount of potentially recruitable lung in RDS patients using the gold standard, which is the CT scan, and they found that there is a large difference between patients with some patients with a low potential for recruitability and some patients with high potential for recruitability. And the first one is coming from Milano, include patients after 3-4 days of mechanical ventilation, and found that has a median value of 13%, which is not much. And the second one include early onset RDS and find much higher potential for recruitability, but both of them show that there is a difference between patients. So it means that when we have a patient in the ICU, for me the first step is to try to distinguish which kind of patient we face, because obviously we cannot use the same recruitment strategy for a patient with a low potential or a high potential of recruitability. Interestingly, the amount of potentially recruitable lung in this study was the only univariate variable associated with ICU mortality. And the patient with a high potential for recruitability have worse prognosis, meaning higher mortality. Why? Probably because these patients are at higher risk of ventilator-induced lung injuries, especially at electroma. So, can we predict lung recruitability? Well, it's not easy at the bedside. We know that according to the severity, the more severe RDS have more potential of recruitability than the moderate or mild RDS. The type of RDS also is important. Extra-respiratory injury have usually more potential than respiratory injury. Non-lobar RDS on the CT scan or chest X-ray have more potential than lobar injury. And the time from the beginning of the disease is important. If we manage a patient early, the alveoli are filled with liquid, protein-rich edema. Now, if we wait 3, 4, 5 days, we have some fibrosis occurring, and then it's more difficult to recruit. So how can we assess recruitability? The gold standard is to use a CT scan at 2 different levels of PEEP and to do complex calculation to assess the amount of potentially recruitable lung. Probably there are some other imaging methods that we can use at the bedside, such as lung echography or EIT, electrical impedance tomography, but we still don't know exactly how to do with this. And what I want to suggest is to use a bedside tool, which is a PV curve. PV is for pressure volume. So a PV curve is a maneuver that we can do on top of the current ventilation that will last around 40 seconds, for example. And usually we use a PV curve between 0 and 40 centimeters of water of inflation over 20 seconds and a deflation PV curve from 40 to 0 over 20 seconds. And we have to go slowly, meaning using inflation-deflation flow below 10 liters per minute, so that the pressure that we read informs about the elastic property of the respiratory system. So if we do a PV curve in a normal lung patient, normally aerated, this is pressure, this is flow. So the slope of the curve informs you about the compliance at each level of pressure. And you see that in a normal lung patient, when you increase the pressure, the volume increases linearly, meaning that the compliance is the same, more or less, all along the inflation. And this compliance here is close to the static compliance that you can measure during ventilation. You can see also in a normal lung patient that there is a small hysteresis. Hysteresis is a surface enclosed between inflation and deflation. All of this surface. There is a small hysteresis that is due to viscoelasticity, a little bit of gas consumption. Now, if you do a PV curve in an ARDS patient that has some collapsed lung and a baby lung, you may see in some cases very different shape with, during inflation, two different slope and a change in the slope. Why? Because when you start increasing pressure, the gas will go in the aerated part of the lung, which is a baby lung, so the compliance is very small because of the baby lung. And then at some point, you see obviously that the compliance increase suddenly above this point that we call improperly low inflection point. Above this point, now compliance increase. Why? Because at some point we start to reopen the collapsed lung. So we pop open the alveoli and suddenly the compliance increase. So it means that in an ARDS patient, if you see this change of slope and this low inflection point, it means that this patient have a potential for recruitability. If you have a line without a low inflection point, it means that the patient have a low potential of recruitability. Then what you can do is to measure the slope of the recruiting part. Because this is a recruiting part of the inflation, the steeper will be the slope, the higher will be the recruitability. And so you can use two cursors here and measure what we call the linear compliance, which has nothing to do with the static compliance. It's just the recruiting compliance during the inflation. And we consider that if it's above 60, it means that the patient have a potential for recruitability. And finally, in ARDS patient, we have to look at the hysteresis, which is the volume between inflation and deflation. You see that in some patients, the hysteresis is much larger than in a normal case. And why? Because in ARDS, hysteresis is partly due to recruitment, de-recruitment. In ARDS, we know that the pressure to reopen the collapsed lung is higher than the pressure to de-recruit the lung or to collapse the lung. So what does it mean? It means that when we inflate the lung, if we recruit one unit, for example, at 20 centimeters of water, this unit will still be open at 20 centimeters of water during deflation and will collapse somewhere below 20. So that's why the volume of the aerated lung is always higher during deflation than during inflation. And the larger is the difference, the more recruitable is the patient. So to measure hysteresis is not easy, but we can easily use a cursor and measure the volume difference at any point. And there is a perfect correlation between hysteresis and the volume difference, for example, at 20 centimeters of water. So that's why in my clinical practice, when I have such a PV curve, I use 20 centimeters of water to measure the volume difference here. And if it's higher than 400 milliliters, there is a potential for recruitability. Now, if you combine the PV curve with the esophageal pressure measurement, as it was shown by Danny Talmor, then for the same maneuver, you can display the airway pressure volume PV curve, so the PV curve of the respiratory system, but also the esophageal pressure versus volume PV curve, the PV curve of the chest wall, and the transpulmonary pressure, airway minus esophagus, transpulmonary pressure versus volume PV curve, which is a PV curve of the lung. And the PV curve of the lung is even more precise than the PV curve of the respiratory system. You see this case, for example, obviously there is no change in the slope during inflation. Linear compliance, I don't know. Very small hysteresis, so probably this patient have a low potential for recruitability. And if we look at the PV curve of the lung, we have exactly the same information. Now look at this patient down here. Again, if we look at the respiratory system PV curve, there is a low inflection point. I don't know about the linear compliance, but the hysteresis is larger. And if we look at the PV curve of the lung, it's obvious that there is a change in the slope, quite high linear compliance, and a large hysteresis. And in some cases, it's not so easy. You have this case where the PV curve of the respiratory system shows a change in the slope, but the linear compliance is 40, so it's not that much, and the hysteresis is less than 400. So you may say, well, I'm not convinced that this patient should benefit from recruitment. But if you look now at the PV curve of the lung, now it's obvious that there is a nice low inflection point, a high linear compliance, and a large hysteresis. So actually, I think this patient will benefit from recruitment and a certain level of PEEP. So to assess recruitability will help us to decide about the ventilation strategy. If we have a low potential for recruitability, I think we should not perform any recruitment maneuver, and we should not use a high PEEP. Recruitment maneuver will be harmful, will over-distend the lung, probably induce a hemodynamic compromise, and high PEEP also will over-distend the lung. So this patient may benefit from prone position, and I think we should try prone position in this patient. The efficacy of prone position is not predicted by the PV curve. The PV curve predicts only the efficacy of recruitment maneuver. Reversely, if we have a patient with a large potential for recruitability according to the PV curve, then we should perform a recruitment maneuver and titrate the PEEP to avoid the recruitment. According to this paper, if we consider early onset ARDS patient, 80% of the patients are on the recruiting side and 20% are non-recruiters. But if you get the patient after several days of mechanical ventilation, then this number will probably decrease. So now we will speak about recruitment maneuver and PEEP titration for those patients who have a high potential for recruitability. What are the conditions to perform recruitment maneuver? The patient have to be passive, so deeply sedated plus or less paralyzed, in stable hemodynamic condition, and we have usually to overinflate the cuff of the balloon because we are going to use a high airway pressure. There are some contraindications that we have to keep in mind before doing a recruitment maneuver. Severe hemodynamic impairment, high intracranial pressure, lung emphysema. We should be very careful about this. Bronchopleural fistula, pregnancy, and right heart failure. There are several methods that have been described for the recruitment maneuver. Manual hyperinflation, I think we should forget this. Sites, which is a periodically increase in either airway pressure or tidal volume, but it's repeated. A sustained inflation method, the pressure control method, or prone position that can be considered also as a recruitment maneuver. The sustained inflation method use an increase in PEEP on top of the current ventilation. Traditionally, it was 40 of PEEP for 40 seconds, and this maneuver in an animal model was associated with some injuries of the airways because of the rapid increase in PEEP from the actual level to 40. And there is an abstract tomorrow showing that also when we decrease PEEP rapidly, this is associated in animal model to some airways injury. So what we use rather is, again, using the PV tool, you can set the top pressure that you want to use, the duration of the maneuver, so you can decide duration, and how fast you want to increase from the current PEEP to the top pressure. So instead of using a very rapid increase, we can do it over several seconds. The staircase recruitment maneuver is done usually using a pressure control with a fixed driving pressure, and we increase PEEP 20, 25, 30, 35, step by step, each step being 2 minutes. Well, what is important in terms of efficiency of the recruitment maneuver, it depends on the pressure that we reach, the duration of the recruitment maneuver, and very important, on the post-recruitment maneuver strategy, which is the PEEP you use after recruitment maneuver. If you perform a recruitment maneuver and go back to a low PEEP, 10 minutes after the recruitment maneuver, all the recruitment is gone, and you will be disappointed and say, well, it's useless. So the tricky part is to find the level of PEEP that will keep the lung aerated. So in terms of pressure, we have some data in this study showing that if we want to fully recruit the lung in early onset ARDS, we have to use pressure somewhere from 40 to 60 centimeters of water. In this study, they show that in around 50% of the patients, 40 centimeters of water was enough, but in 50% of the patients, they had to increase the pressure for the recruitment maneuver up to 60 centimeters of water. And why? Again, I show you this slide that was shown by Danny. If you plot airway pressure and transpulmonary pressure, when you apply 40 centimeters of water of airway pressure, you see that the transpulmonary pressure can be as low as 10 centimeters of water. 10 centimeters of water of transpulmonary pressure is probably not sufficient to reopen the collapsed lung. So in order to reach something like 20, 25 of transpulmonary pressure, in some patients, we may have to increase airway pressure to 60 centimeters of water. Regarding the duration of the recruitment maneuver, in this study, we performed sustained inflation recruitment maneuver at 40 centimeters of water for 30 seconds. And we were able to measure the volume increase during the recruitment maneuver. So you see, each line is an individual patient. We had 50 patients. In some patients, we did not recruit at all. And in some patients, we recruit 200, 400, or even more. But what you can see is that all of the recruitment occurs very early during the recruitment maneuver. More or less, after 10 seconds, everything is recruited, and there is no point to maintain the recruitment maneuver for more than 10 seconds. In the same time, we measure the systolic arterial pressure during the recruitment maneuver and after the recruitment maneuver, and we found that during the first 10 seconds of the recruitment maneuver, the systolic arterial pressure is maintained and start to decrease after 10 seconds. So the practical message of this paper is that if we use a sustained inflation recruitment maneuver, 10 seconds is sufficient to recruit what has to be recruited and to avoid, as much as possible, the hemodynamic compromise. Now, if we perform a recruitment maneuver, how can we assess that this is efficient? Can we look at SpO2? Well, not so much, because usually SpO2 will decrease right after the recruitment maneuver as an index of the hemodynamic compromise. Can we look at the gas exchange? Yes, if we do a blood gas after the recruitment maneuver, the PEEP setting, if we note an increase in PaO2 and a decrease in PaCO2 with the same minute ventilation, probably it means that the recruitment was efficient. We can look at the respiratory mechanics, doing another PV curve, or looking at the compliance, but there are a lot of pitfalls to assess recruitment looking at the compliance of the respiratory system. We can use lung imaging, again, CT scan, EIT, or echo. Probably we can assess recruitment by this. And we can use also a direct volume measurement. I will show you what I mean. If we perform a recruitment maneuver, for example, at 40 centimeters of water for 10 seconds. This is the ventilator, this is the lung, and this is the proximal pneumotachograph. The ventilator will maintain the airway pressure at 40 for 10 seconds. If we have some recruitment occurring during these 10 seconds, the total volume of the aerated lung will increase. As a consequence, the pressure at the proximal airway will decrease a little bit. So the ventilator will inflate some little spikes of flow just to maintain the pressure at 40 centimeters of water. And because we use a proximal pneumotachograph, we can track these little spikes of flow during the 10 seconds. If we integrate them, we get a volume. This volume here is an assessment of the volume increase of the lung, of the aerated lung, during the 10 seconds. Of course, if there is no leaks, that's why it's important to make sure that we have no leaks on the circuit. So this is what you can see on the screen. Here we perform a recruitment maneuver at 40 centimeters of water for 10 seconds. So you see the pressure increase to 40. And during the 10 seconds, you see that the volume increase. This volume here that we can measure, around 400 milliliters, is an assessment. It's not a precise measurement, but it's an assessment of the volume increase during the recruitment maneuver. Again, if you look transpulmonary pressure and recruitment maneuver, you can even be more precise. This is a patient in which we increase the airway pressure at 50 centimeters of water for 10 seconds, and we notice a quite large increase in the volume. Now, if we have an esophageal pressure, we can display the esophageal pressure versus volume recruitment maneuver, and you see that there is no recruitment on the chest wall. This is what we expect. And if we display transpulmonary pressure recruitment maneuver, you see that all the recruitment is due to the lung, which is expected. But also, you can see that during the recruitment maneuver, the transpulmonary pressure, in this case, was around 24 centimeters of water. So this is a goal when we perform a recruitment maneuver. We want to recruit as much as possible, but we don't want to harm the lung, to put too much transpulmonary pressure. So I think we should target a transpulmonary pressure around 25 centimeters of water, which is probably enough to recruit the collapsed lung, but not too much to injure the lung. So if you use a transpulmonary pressure, you can titrate the airway pressure that you need to reach around 25 of transpulmonary pressure. The last question, and I won't detail it, is how to set PEEP after the recruitment maneuver. Well, I like the method to use the end expiratory pressure, the end expiratory transpulmonary pressure, but we don't have always this method, so there are some other method that has been described, and this is a very crucial point to maintain the lung recruited. So to conclude, I think that assessing recruitability is a prerequisite for a rational decision about recruitment and PEEP setting. This is a first step that we should do at the bedside. And to do this, a very easy tool is a low-flow inflation and deflation curve, for example, from 0 to 40. And then to keep the recruitment strategy only for the patient with high potential for recruitability, and for the other one, to keep a low PEEP, a low driving pressure. If the patient is a recruiter, we can perform any recruitment maneuver, but the sustained inflation is very rapid, 40 centimeters of water up to 60 for 10 seconds, and the setting of PEEP is very important. All this, the assessment of recruitability and the recruitment maneuver will be even more precise if we combine it to the esophageal pressure measurement. It's not a must, but when the patient is really serious, with a serious hypoxemia, I think it's useful to combine both. And we have to keep in mind that recruitment should be an early goal in the management of RDS. If we do it at the beginning, it will be much easier and more efficient than if we wait 3, 4, 5 days. I thank you for your attention.
Thank you very much. Any question from the floor? Please.
Thank you for your excellent presentation. I have a question on the hemodynamics and the patent foramen ovale opening during the recruitment maneuvers. We observed that in patients that we had huge recruitable volume, but we maintained for 20 seconds the recruitment maneuver, we have in some patients a massive opening of the patent foramen ovale, and at the same time we have an impressive drop on SpO2. Can you comment on this?
Well, I probably have I'm less cautious than you about this, but yeah, I think you are perfectly right. We should be very careful about hemodynamic during the recruitment. And what I learned is that if we look at only systolic arterial pressure. When systolic arterial pressure decreases, it means that already the cardiac output decreased a lot. So that's why, in my experience, using short recruitment maneuver, 10 seconds, does not avoid every hemodynamic compromise, but limit the hemodynamic compromise. We don't check if there is we don't check the cardiac echo before doing this.
Yes, but my question is, when we recruit enormously the lung, at the same time we're increasing the pulmonary vascular resistances. I'm speaking about patients in whom we have massive recruitment with high levels of recruitment maneuvers. And at the same time, we don't observe this in patients where we don't recruit the lung. We observe a drop in SpO2 and passive and pattern foramen ovale opening in patients in whom we have massive recruitment.
Well, if you look at the Grasso paper, I think it was reverse, meaning that the recruiters have a better tolerance than the non-recruiters.
Hemodynamically.
Yeah.
In the PFO opening, we don't observe the PFO opening in non-recruitable lungs.
Yeah, they didn't measure it.
João Batista Borges from São Paulo in Sweden, Uppsala. I'd like only to thank you for your lecture and only to reinforce a point. I think I really would like to reinforce the idea that we should go more for titration of recruitment. It's related to the concept of to see how much is the potential of recruitability, but it's a little bit different because, for instance, if we test the potential of recruitability when going to 40 centimeters of water, many patients will conclude that it's a very low potential of recruitment. But if you go to 50, you change the scenario, the same patient you have a moderate or high potential of recruitability. I mean, my point is that I'd like to reinforce the point that as we did in some years ago with Marcelo Mato, that we should work on a titration of the potential of recruitability. So a small test that you could really tailor. We are talking so much of individualized medicine nowadays. We can really, with some range till 56 centimeters of water in a few seconds, we can see better the potential of recruitment. It titrates. Some patients is really completely open with 40. Some patient needs 60, and you'll be stamped like low recruitable because it was not tested for higher pressures. I mean, I'd like to reinforce the point to titration of recruitment maneuver as well, PEEP.
Yeah, I think you're absolutely right, and it's a very good point. Well, we do the PV curve from 0 to 40 in all the patients because already the PV curve in some patients have some hemodynamic compromise, so it's sort of safety decision. But you're right, some patients, we see obviously that they have this low inflection point at very high pressure, 30, 35. It's very unusual that it's above 40, but if I have some doubt, I may do a second PV curve going to 50 or 60. But it's usually, in my experience at least, if the patient with a low chest wall compliance, so at the beginning of the curve it's totally flat until 20, 25, and then we start to reopen some lung above this very high pressure. So in this case, for me, it's an information that I will have to use high pressure to recruit and probably high PEEP to maintain the lung.
We suggest in that paper in the Blue Journal is the stepwise recruitment maneuver. The stepwise maximal recruitment maneuver at the same time a titration of the opening pressures and going to the level that each individual patient needs. Then you can stepwise and see which is the level that we need there. Thank you.
Yeah, thank you.
Alberto Hernandez from Spain.
Can you come to the microphone, please?
Yeah, from Spain. Thank you very much for your lecture. I would like to ask you, you propose a PV curve between 0 and 40 centimeters of water, and why not between 10 and 40 and you avoid desaturation due to losing PEEP during that time?
Sorry, I don't, can you repeat?
You said about using PV curve from 0 to 40 centimeters of water.
Yes.
And why not start it at 10 so you avoid the saturation due to zero PEEP during that time?
Well, first, when you go to zero, I don't think there is a lot of harm because it's for a short period of time. So in my experience, you don't see de-recruitment when you go down to zero and increase. And in some patients, you see that this low inflection point may be below 10. So that's why we prefer to start at zero, to be able to track this change in slope all the time. That's the reason.
Please.
Chris Lowe from the UK. I've just got a very practical question. How often do you perform your checks for recruitability and your recruitment maneuvers? And of course, once you break the circuit, when your patient de-recruits, like for example after suctioning, would you re-recruit them after that and perform another maneuver?
Yeah, that's a very important point. We try not to do too many recruitment maneuvers because each time there is overinflation, maybe hemodynamic compromise. So we tell to the nurse, after the recruitment and PEEP setting, don't suction the patient except if it's really needed, but don't suction systematically. And usually during the first 24, 48 hours of RDS, you don't need to suction the patient. They don't have a lot of secretion. But if they do, if they have to do, or if there is an accidental disconnection, then we will probably perform another recruitment maneuver. Regarding how often do we have to reassess, it depends on the patient. If you do all this and select the PEEP, usually we keep the same PEEP for at least 12 hours, 12 to 24 hours. Because if we try to decrease it too rapidly, then you have some de-recruitment again. But this depends also on how much fluid did you have to give to the patient. Suppose the patient is in septic shock and you still need to give some fluid, then the lung is more wet, more heavy, and you have to reconsider after 12 hours maybe to compensate by increasing a little bit more the PEEP.
Okay, thank you very much. We have to proceed.